Good afternoon, everyone. First of all, I'd like to thank the staff here and for a wonderful lunch. Can we just give the team an applause for that amazing lunch? And please inquire about some of the vegetarian options and some of the local vendors that supported that. It was just absolutely amazing. And as we transition from the conversation this morning and even the conversation last night, we want to now think about transition to this conversation of from yesterday to today, lessons learned from the past and practices in place. So we've assembled partners here today to talk about some of the things that we've learned from the past and what actions we're taking today. So I'm going to start the conversation with Dr. Martin Mendoza. Dr. Martin Mendoza is Director of Health Equity and serves as Director of Health Equity for the All of Us Research Program. In this role, he provides leadership and high-level expertise to improve inclusion and equity in precision medicine and address health equity issues for the program. Before joining the All of Us program, Dr. Mendoza served as Director of the Division of Policy and Data at the Office of Minority Health in the Office of the Secretary at the U.S. Department of Health and Human Services, charged with developing health policies and initiatives to eliminate health disparities and advance health equity. Previously, he led extramural research for minority health in the Office of the Commissioner at the U.S. Food and Drug Administration, the FDA. He's a recognized expert in clinical trial diversity, and while at the FDA, testified before Congress in support of diverse clinical research inclusion. Dr. Mendoza is also the primary author of the pivotal FDA guidance document, Collection of Race and Ethnicity Data in Clinical Trials. Thank you, and please, Dr. Mendoza, happy to have you here today with us.
Thank you so much for that introduction, Dr. Watson, and thank you to the organizers for the opportunity to really be here in this really historic and what I consider sacred place. And so, you know, I think before we get started today, and even though we talked a lot about this yesterday, I feel like it is worth repeating and acknowledging the history of this town and, you know, the transgressions that occurred here by the U.S. Public Health Service to this community, as well as to the family of Miss Lax. And you know, and even though it's been many years have passed since those events, I think we still need to remain vigilant and aware so that something like that, you know, just never happens again. You know, I don't think it's something that we can ever, you know, put our guard down for. And so I do want to start today by, you know, talking about how I view health equity and just what is health equity, because that's a term that gets thrown around a lot. And so as I view it, I see health equity as the attainment of the highest level of health for all. And to me, health equity is personal. I have had, like I'm so sure so many of you, I have had a family that has been ravaged by health disparities. Both of my uncles were double amputees. Sorry, both my grandfathers were double amputees that died from diabetes. My mother, who was all of 95 pounds and 5'2" on a good day, she lost her life after a routine a routine surgery to place a stent after developing coronary artery disease 72 hours after that stent was placed, which should have, it was a routine surgery that should have just never happened. And so, you know, these are, you know, just the tip of the iceberg, because I know that so many of you have so many similar stories. And these things they should not be happening within the medical community that the practices that we have today. You know, there's just no excuse for these types of things to be happening. And so when we think about health equity, I think it's really important to distinguish it from equality. So equality means that you treat everyone the same. But, you know, I don't think that's not good enough, and that's where equity comes in. Equity acknowledges and practices that there are some groups, through no fault of their own, are going to need additional assistance, additional help to achieve those equal outcomes. And so I think that's a really important concept that we need to think about. It's just not enough to treat everyone the same. We have to do whatever is necessary to make sure the outcomes are the same, but not necessarily the effort, because as I just said, there are some groups, some populations that, that we need to provide more assistance to. And so as Director of Health Equity for the All of Us Research Program, my vision is really to build a research program where health equity is a reality for all, and in particular, to ensure that equity, diversity, inclusion, and accessibility, that they are foundational to every part of the program, from our researchers to our participants to our communications to our technology. Everything needs to have equity at its foundation, and that's what I'm charged with. And so really, what does that mean? First and foremost, I think our focus is rightly on our participants, and ensuring that we respect them, and that their potential contributions to the program, and to make sure that we are committed and really 100% focused on being a lifelong partner to improving their health and the health of their communities, and that we do this not just through our words, but through our actions, because I know that that's what really matters. Similarly, a focus on our researchers. It doesn't do us any good if we just have the same big universities, the Hopkins, the Stanfords, accessing our data. We need our diverse researchers, like those folks here at Tuskegee and other HBCUs, Hispanic serving institutions, minority serving institutions, to come to the table, to come to the research table and be partners with us. And so again, really, I'm focused as Director of Health Equity to ensuring equity is part of everything we do here at All of Us. And so I look forward to the conversation, and great to be here today. Thank you again, Dr. Watson.
Thank you, Dr. Mendoza. Next, I have the pleasure of introducing Dr. Shantice Allen. Dr. Allen is the Community Engagement Core Director of the All of Us Southern Network. She's an assistant professor in the Department of Environmental Health Sciences at the University of Alabama, Birmingham School of Public Health, where she teaches and conducts research in the areas of environmental justice, environmental health disparities, and health equity. She also serves as the state PI for the Rural Heart and Lung Cohort Study. In that role, she is responsible for developing high-quality research engagement and retention experiences across multiple regional teams. A two-time graduate of the University of Alabama in Tuscaloosa with a BS in biology, a MA in human and environmental sciences, and a PhD in health education and promotion from UAB. Dr. Allen has over 15 years of experience in engaging both urban and rural communities in longitudinal research projects, deployment of community-informed data collection methods, and enhancing community participation and influence in research in an effort to serve unique populations and systematically excluded communities. Thank you so much.
Thank you. Thank you, everyone. Real quickly, I do want to also kind of center myself in terms of my connection to Tuskegee. I am the product of two graduates of Tuskegee Institute, and they would kill me if I didn't say that. Tuskegee is home. I was born here, and it's really great to be back here. So again, it's just an honor and a pleasure to work with the All of Us research program and to be here at home in Tuskegee. So I'm going to talk a little bit about just, the title of and theme of our panel is from yesterday to today, lessons learned from the past and practices in the past. Next slide. So I want to do a little bit of contextualizing of rural communities, because we are in the rural South. And so to give you a little bit of insight and data into this area of the country that we know as the rural South, but some of you also may really have some understanding of ruralness from your own perspective. First, there are 46 million U.S. Residents that live in rural areas in 2020. That made up about 14% of the U.S. population. That's a lot of people in rural communities that need support. But that's also a lot of people in rural communities that have a lot of connection to various ways of what health is and what that looks like. And there's also so much to learn from rural communities as well. The vast majority of older age counties with more than 20% of their population are age 65 and older, they're in rural areas. So basically what that means is there are a lot of older individuals that are in rural communities. And when we think about how do we support rural areas, how do we work together collaboratively to support those across the lifespan, essentially, but definitely those who are older in age, it requires all of us to do that. And some of the earliest public health literature includes reports on infectious disease and sanitation in rural areas. We learned about distancing, talking about COVID from Dr. Maxwell's previous presentation. We learned how to do that in rural communities first. There are a lot of firsts that happened in rural areas. We learned about sanitation practices in rural communities first. So we can't negate and neglect the fact that the things that we know to do now, a lot of those lessons learned came from rural and remote areas. And we're often accustomed to thinking that urban spaces are designed and rural spaces are natural. However, the same concepts in terms of urban sprawl and cities getting bigger and people driving big gas guzzling trucks and lots of highways being built and not good public transportation, those same kinds of decisions are also at work in rural communities as well. So when we think about, because it forces planners and decision makers to make choices about how do we use space in order to create healthy environments. So the same way that people are thinking about how do we make buildings bigger and things closer or farther away, they're thinking, those same kinds of folks are making those types of decisions in rural communities as well. Next slide. So why focus on the rural South? And there is a photo here. I'm not sure where it went, but because it's actually a mobile unit from Tuskegee back in the 20s. I would love to show that. But why are we focusing on the rural South? And I serve as the core director for the Southern network of all of us. But there's a reason why this area of the country is important in terms of emphasis. And we heard a lot of that last night from some of our panelists, and I'll just refer to it again. There are rural political values that have made public health activities particularly challenging. You heard Dr. Dina talk about, hesitancy with COVID vaccinations and people being concerned about getting out and actually doing that. That's not new. That thinking isn't new, but there's certainly things that we can do to combat that. And, there's lots of, in terms of scholars, that have been thinking about this issue and how do we acknowledge, obviously, that there are challenges and then move beyond them. There are people who are working in that space every day. Kamara Jones is one of them, if you all know her, who's was at Morehouse. I think she may be somewhere else now because pardon me? CDC, yeah, she's definitely been with CDC. Thomas Levis, who's at Tulane. David Williams, who's at Harvard. These are people who have been thinking about, how do we look at what happened in the past, how people are thinking about political climate now in terms of health. And over the past 50 years, the public health profession definitely has improved at identifying structural inequities in health. We know that racism is a public health issue. Yes, it is. We know that people's attitudes around race have impact on how healthcare is delivered and received. Those are things that we do understand. But when we start thinking about how do we actually put that into action when we're talking about doing things in rural communities, there's still so much to learn. Not only, again, from things that we know from the past, but also how we think about things in the future. And again, there's been lots of people who have been working to identify a number of those determinants. Next slide. Sorry, that photo didn't show. That's sad. One of the reasons why we're here is this planning committee, which is an amazing group of people who have been working very hard together over the last several months, have been thinking about this conversation around the importance of research. And I think it's important, and I know that Dr. Watson understands this. We didn't want this to be a program just about all of us. We wanted to have a conversation about the importance of asking questions and answering questions, and asking the right questions. Because there's a difference between asking a good question and asking the right question. And what we want to do with the All of Us program is allow the opportunity for the right questions to be asked and answered. And so this is just some data from a group out of Utah that looked at, and they're a part of the All of Us program. They did a landscape analysis of engagement. So when we talk about engagement as a part of the research process, you have to do this. You have to ask people and have these types of conversations about why it's important to do this in the first place. Why should we even care about precision medicine? Why do we need to understand that there are differences in terms of how people actually respond to a particular treatment versus another? Those are the right questions to be asking. So this group wanted to know, why is it important to include diverse populations in research? And this is just a bar graph, and the tallest bar set shows you that lots of people wanted that question to be answered. They wanted to understand that better. What population research, what is it? And how will it be carried out across the network, and why is it important to improving health? That was the second bar here. So you see that there are people that are interested in this, and this was done across the All of Us network in terms of the importance of understanding research. Next slide. And again, it looks like there's a graphic that's missing here. But I just wanted to talk a little bit about the All of Us Southern Network itself. So it's the largest network, I believe, of the All of Us research program. It's comprised of 3 different states with a number of different sites connected to it. I'm at UAB. Some of my colleagues in the back are also here representing UAB, and that just went away, and that's okay. That are representing UAB, but we also are doing work with colleagues at the University of Mississippi Medical Center in Mississippi, and we're also working with Tulane and LSU in Louisiana. But why is it, again, important to do this work in the South? We know that there are all kinds of differences in health outcomes in the South, correct? We know this. We had some conversation about this last night. And so the emphasis, and I appreciate this with the All of Us research program, is to put some emphasis on what is happening in the southern region of the country. And there are so many things that we can learn how to do correctly from those who live here. And so you all being here this afternoon now is an important part of the Southern Network's mission, really is to focus on and emphasize those who are in the southern part of the country, because there are lots of health disparities that are here, and then asking those right questions. And so what I've been trained to do as a researcher is to ask questions and then come up with ways to answer them. But the way that you do that is together. I don't do that as Shantice Allen only. I do that with a number of other people alongside of me who have great ideas of how to engage communities. They have interesting strategies on how to talk to people. For instance, you go where folks are. The men in the room, how many of you all get your hair cut on a regular? Maybe. I know we're still in this interesting phase of COVID. But you go where men are notorious for not wanting to go to the doctor, and also oftentimes not, wanting to participate in research projects, and that is completely understandable. But when we're talking about engaging communities in a meaningful way, you go where people are. So going to the barbershop, going to where you get your car serviced, going to athletic events, those kinds of things, that's where research opportunities can happen. I shared this at our regional meeting the other week. I was in the drive-through a few weeks ago at Full Moon Barbecue. That's where I was because I like Full Moon Barbecue. And I had on an Olive Us shirt, and I was just waiting for my food at the window, and it happened to be a little bit of a long wait. And the guy asked me, young black male asked me, he said, "Are you a doctor?" And I said, "Well, I'm not the kind of doctor that I think you're thinking I am, but yes." And he said, "Well, I see that you got this All of Us thing on your shirt. Tell me about it." And we literally had a conversation about the All of Us research program in the drive-through at Full Moon Barbecue. So there's opportunity everywhere to talk and engage and have meaningful conversation about this. I have no idea whether or not that conversation will lead to this gentleman wanting to participate in the All of Us research program, but it was a window that you never know where those windows of opportunity might be. And when they do show themselves to you, show up, be present, take advantage of those opportunities to talk to people. You just never know where there may be that space to do that. And this was in Birmingham, Alabama, in the middle of a Wednesday night or something, and we were just chatting about what it was. I paid for my food, he thanked me for that, and we moved on. But don't underestimate the opportunity to talk about this. I think Dr. Maxwell Dina was saying, just talk to people. Just have the conversation. It's important to do, and it's definitely important to do in this part of the country where we oftentimes we don't want to talk about these things, but it's important to do that. And I think with that, I don't know if the next slide, I believe in it, may be another graphic that won't show, I'm sure, I don't know, is I want to leave you with this. One of my favorite quotes is from Paul Wellstone, who was a senator from Minnesota back in the early 90s until 2002. And he made the comment that we all do better when we all do better. And I want to leave you with thinking about that. Your individual pursuits, what you want your family's legacy to be, what you want your own legacy to be, really is accomplished when we all do better. We all do better. Thank you.
Thank you so much for that. I wrote that quote down. I'm gonna go now to Dr. Altavis Ewing. Dr. Ewing is a clinician scientist and genomic health equity thought leader with 15 years of genetic counseling and health disparities research experience. She earned a PhD in genetics and human genetics with a specialization in genetic counseling from Howard University and completed a cancer health disparities postdoctoral research fellowship at the Johns Hopkins University Bloomberg School of Public Health. Dr. Ewing dedicates her career to ensuring that emerging genetic and genomic research services and technologies do not further exacerbate health disparities and inequities. Her unwavering passion for equity and inclusion enables her to serve as a trusted and committed healthcare liaison to marginalized, medically underserved, and underrepresented communities such as her own in genetics and genomic research. As a first-generation college graduate and African-American woman from rural Tennessee, Dr. Ewing's scholarships focus on inclusion of diverse populations in cancer genetics research and the development of ethically sound and educational and engagement strategies to better serve and address the needs of medically underserved populations. From 2020 to 2022, Dr. Ewing serves as Director at Large on the National Society of Genomic Counselors Board of Directors, where she established and influenced strategic priorities among the NSCG. Currently, Dr. Ewing is a senior science lead and strategist on the Global Health Equity and Population Science team at Genentech. She is also a diversity, equity, and inclusion DEI advisor to the Keene University Genetic Counseling Program and a medical health advisor to the Chrysalis Initiative. Tulsa Initiative Lab and Susan G. Komen stand for HER, which is the Health Equity Revolution Initiative Genetic Counseling and Testing Working Group. Thank you, Dr. Ewing.
Thank you very much, Dr. Watson. It's always really embarrassing to hear your long biography, so thank you for doing a great job. I want to first start by saying thank you to Dr. Watson, thank you to the All of Us research team, thank you to Bethel Missionary Baptist Church, thank you to Tuskegee University, and all of the other planners who have done a marvelous job of really convening a wonderful and informative event today. And I'm immensely grateful because this is really an opportunity for me to live in what I truly am convinced is my purpose. So as you may have heard in my biography, I am a genetic counselor. And some of you may be aware of genetic counseling, some of you may not. But genetic counselors, we are healthcare providers who are really poised to help translate and deliver complex genetics and genomics information to all populations. Some of us may work in prenatal settings, some of us may work in community settings, cancer settings, or even at universities. But for me, I actually did not learn about genetic counseling until I was a senior in college, so pretty late in my training. And actually, it was my fall semester senior year. And at the time, I was torn between medicine and a career in research, laboratory research. But I knew deep down that I really wanted to interact with patients, and I knew that I really wanted to interact with people on a daily basis and be able to discuss science and medicine with people on a daily basis. So the day that a genetic counselor came and presented to my senior genetics course, I really felt like a career option that had been a secret for so long had finally been availed to me. I saw genetic counseling as an opportunity for me to meld my love for people, my love for science, medicine, and really be able to connect the dots between my passions for family history and family health history. And I saw the opportunity to link those two to really help people, one, fall in love with learning more about their heritage and their family history, and to recognize that by learning that information, we can learn more about the conditions that are plaguing our families, the conditions that oftentimes some of our family members are diagnosed with that we may not know about. And if we are able to connect the link between the two, then we're able to share that information with family members so that we can make informed health decisions to hopefully help our family members live longer and better quality lives. So for me, that is really what motivated and prompted me to go into the field of genetic counseling. And I will also share that at the time when I learned about the profession, there were a lot of statistics about the disparities between Black and white women diagnosed with breast cancer. Although white women are more likely to be diagnosed with breast cancer, Black women were more likely at the time and still are today to really suffer disproportionately from morbidity and mortality rates when it comes to breast cancer. And for me, again, learning about genetics, learning about the fact that the human genome had just been sequenced a few years prior, I really saw genetics as a tool that could be used as one of the important tools in our toolkit to really help our populations better understand their risk for disease, be able to manage disease, and maybe even be able to prevent the onset of some of those diseases. I'll also admit that at the time, there were also a lot of statistics about the underrepresentation about various populations in various science and medical fields. And I knew that that would be the case for genetic counseling as well. However, I did not know that the statistics would be so stark. So actually less than 2% of genetic counselors identify as people of color. And that's something that I am very passionate about changing every single day. That's why anytime I get a chance, I'm always trying to spread the word about genetic counseling and how we work really closely with various populations, various communities of color to, again, translate that complex information that some people deem scary, into information that can help us, again, make those informed decisions to really be in control of our health and to, again, help our family members. So shortly after graduating from Rhodes, I actually did not matriculate directly into a genetic counseling program. I taught middle school science for 2 years, and I loved being immersed in the middle school setting. However, I also realized that teaching at that level was not my calling. So I yielded and again pursued that profession in genetic counseling. And for me, there was really no question that Howard University was the institution that I would call home. It was the only historically Black college and university that actually housed a genetic counseling program at the time. And Howard's vision, Howard's mission was truly aligned with who I considered myself to be as a person and as a woman coming from a rural area where I saw disparities in action, and I really wanted to be able to change those disparities. For me, I started out in my genetic counseling program thinking that I would go into pediatric genetics. However, I quickly detoured during that time. And it was actually during my cancer genetic counseling rotation where I felt called to go into cancer genetic counseling. And that's really because as I sat as a person in a rotation as a trainee, and I saw the young women who were diagnosed with breast cancer walk through the door seeking genetic counseling services, seeking access to genetic testing, answering the questions to determine if they were eligible for genetic testing, but being told time and time again that they did not meet criteria for testing. So they were turned away from being able to access what I considered a potentially life-saving resource. Because if we were able to offer genetic testing to someone who has breast cancer or various forms of cancer, there's a possibility that we can identify the cause of the cancer, and not only can we potentially tailor someone's treatment based on a mutation, based on a change in someone's DNA that may have caused their cancer, but we may actually be able to prevent the onset of additional cancers as well that may be associated with that particular DNA change. And again, I saw young Black women, young women of color, being told time and time again that they did not meet criteria for genetic testing. So for me, that was very unsettling. It was very disturbing. And it made me realize that we are not asking the right questions. And we are actually asking the questions that are guided by the data that we have at our hands to date. But most of that data is characterized or is representative of people who do not look like me, of people who do not look like the women who are being told time and time again that they did not meet criteria for testing. And that actually motivated and prompted me to not only continue my genetic counseling training, but to also pursue my PhD so that I could ask the questions that no one else was asking, so that I could partner with the scientists who are also passionate about inequities and disparities and actually bring that to the genetics and genomics setting. So that is what caused me to go into cancer genetic counseling ultimately. And after I finished my doctoral training at Howard, I knew that I wanted to always be a critical resource for the community to, again, be able to translate that genetics information to the community in a way that they could value and use to inform their health decisions. So during my postdoc, I had the pleasure of really getting immersed in community-based participatory research. So really partnering with the community to come up with the important research questions that needed to be asked. And not only coming up with those research questions and executing the methodology, but also when it came to publishing those results, I made sure to circle back and to partner with those community partners to ensure that we wrote the manuscript together and that we actually translated that information, not only in the form of a scientific manuscript, but also translated that information in a way that the community members would have access to that information. That was something that I was very passionate about and persistent in ensuring shortly after my postdoc to make sure that that information got back to the community, again, the people who partnered with us to really deliver on that research. And I'll end by sharing that as a genetic counselor, my journey started in a clinical setting, and it led me to a research setting. And I really struggled because, again, I wanted to go into this space to serve as a trusted messenger and a translator of genetics and genomics information. But I wasn't sure at times if that meant that I had to serve as a clinician or if I had to sit in the ivory tower or go to an academic institution to come up with the research questions and to also be able to train the next cadre of genetic counselors. But I can say that my career has been very rewarding and fulfilling as I have been able to influence and encourage young students to look into the profession of genetic counseling. I've been able to partner really closely with a variety of different communities to be able to speak, to share information about cancer genetic counseling, genetic testing options, and genetic research opportunities that are available. And I've also been able to serve in leadership roles within my national society as well. But for me, opportunities like this are really the ones that affirm that I am in the right space and that really our ability to actualize the promise of precision medicine with the use of genetics and genomics so that we can ensure that everyone benefits will only become reality through projects like the All of Us Research Project. So again, I'm truly honored to be here today, and I look forward to our discussion.
Thank you all so much. I want to start with Dr. Mendoza. I want to kind of frame it and almost with what Dr. Ewing ended with, this concept of 2%. You said 2% of genetic counselors reflect the populations that carry the greatest burden of disease, right? Underrepresented racial ethnic minorities. And when you think about, I often say the messenger matters, right? And there's research that shows that when a research team is diverse, when teachers are diverse, when teachers reflect the communities they serve, we actually have increase in learning opportunities. In the same research, we have better outcomes. But when we think about diversity in clinical trials, we see those similar statistics. We see single digits, less than 10% of African Americans participate in cancer clinical trials. And when we think about system-level changes that need to happen to improve that, what have you seen from some system-level changes, Dr. Mendoza, to help improve those statistics?
Thanks so much for that question, Dr. Watson. So to answer that question, I first want to ask a question of the audience. Don't raise your hand, but I want you to think in your mind, how many of you have ever taken or are on a prescription medication? Now, if you answer yes in your mind, that medication, as you may know, went through a clinical trial that was submitted to the U.S. Food and Drug Administration for approval and was eventually approved. What you may or may not be aware of is there is a greater than 90% chance that that clinical trial that was used to approve the drug or medical device or biologic like a vaccine that you have taken or are currently on, that those participants in those trials were mainly of European ancestry. And so what does that mean? That means that we don't know for sure just how effective that medical product, that drug, that device, that biologic is for populations other than those that were in the trial, so the European population. So we don't know how it's particularly going to work specifically in African Americans, Hispanics, Asians, name your racial or ethnic group of choice. So this is a problem. It's a huge problem, and one that we've been struggling with, as in the research community, for decades. So, as I mentioned, as Dr. Watson mentioned, from 2014 to 2019, I had the opportunity to work at the U.S. Food and Drug Administration, and this is the entity that is the gatekeeper for companies that want to market a new drug, a new device to the public. And so in 2016, I released what was called an FDA guidance document. These are, for anyone not familiar with that is, it's a major policy document that's paid close attention to by pharmaceutical companies, and it tells the companies what FDA is thinking on a particular topic related to clinical trials. And so in this guidance document, what I proposed at the time was that for any company that wanted to have their drug approved by the FDA, they needed to submit a plan with that application that talked about how they would go about including diverse communities within their research. Mind-boggling that this was not a requirement. I just couldn't understand it. So I put forth this idea in this what we call a guidance document. Again, it's guidance, it's not law, but these things are, they're generally well paid attention to by the private sector. And so as of December of 2022, as part of the budget that Congress passed for the rest of 2023 and beyond, that idea that I put forth, that there was a plan that needs to be submitted to address inclusion of these diverse populations, that is now the law of the land. So this is an example of a slow but progressive change that is needed and has been made. What it does not say is that there are certain levels, there are certain, it doesn't establish participation levels for specific communities. So that is a potential area where the law needs to be amended. But we have made this small, incremental, but important step of now forcing companies, universities, even the NIH, that they must think about this and create a specific plan to address the inclusion of these important diverse communities within their research. They cannot and should not be an afterthought. And now that is the law of the land.
Thank you. And before I go to you, Dr. Allen, I want to open it up to the audience, too. If you have a question, please, there's a microphone on this side and a microphone on that side as well. And Dr. Allen, while people are coming and posing their questions, one of the things that Dr. Mendoza just mentioned is the access to participate in clinical trials as well. And when you mentioned rural communities, and this concept of access comes up, I actually did some focus groups with populations, and there was this, it's not a myth, there's a lot of medical mistrust why some communities don't participate, but one of the biggest reasons why some populations don't participate is because they don't have access or awareness to the clinical trials. What are you all doing in UAB and some of the efforts that you're making to ensure that we address these issues of access and awareness?
Well, as I mentioned before, we're going to where people are. You show up, particularly when someone invites you to their house, and they're having an event or a gathering, and they're expecting you there, then you show up. And that's what we're doing. So there's a lot of work that's happening with mobile units, where we're taking the science to those individuals who may not have access to that. There's also obviously telemedicine and the use of technology, but that does come with its own challenges when we're talking about working in rural settings. But you show up. That's what we've been doing, is being present, and being present in a meaningful way. I think it's important that people understand that you don't just show up with what you want to do, but you're showing up with something that will benefit both parties. And you should be leaving something behind.
That's right.
It cannot be. We talked about helicopter science last night. You can't just show up when it's convenient for you to do so. I'm actually going to be I'm just going to share a quick story. I will be in Chilton County on Sunday at a church talking about the All of Us research program, but Sunday is also Super Bowl Sunday. But I was asked to come, and I'm showing up because that's what they want, and so I'm going to be there. But I think it's important to show up. It's important to show up in a meaningful and authentic way, and it's also important to leave something behind.
I agree. Thank you so much for that. See, we have a question right over here, and then we'll come to the question over there.
Good afternoon to everyone. Again, my name is Bernice Frazier. I'm the chairman of the Macon County Healthcare Authority. I have a couple of things I wanted to say. One is the Healthcare Authority is working on developing outreach and telemedicine, and we're also going to do a modern version of the Jessup wagon. So I was so pleased to see that in your presentation, and I look forward to us working with all of us to incorporate that. My question leads back to what, kind of piggybacking on what I asked yesterday about the details. So I saw on your slide of those locations that were enrollment and unenrollment. So if you could share with the audience here, because a lot of times we won't ask, but then we have a feeling about that Tuskegee is not an enrollment site. And so could you explain why, so that people don't have that misconception like, oh, okay, so they're good enough for us to come and do this, but we can't be an enrollment site. So can you share that that reasoning with us?
Sure.
Thank you.
So a lot of the enrollment sites in the Southern Network are and I did not make this decision, but they're typically tied to a healthcare organization or some type of hospital setting. Now we've got the VA here, but Montgomery is a site as well as Selma. So I think the rationale at the time was, how do we I guess, consolidate and use effort in a way that's efficient, is my understanding. But I don't think that means that Tuskegee couldn't be an enrollment site. It just was not one at the beginning of the Southern Network forming. And, we can certainly talk about that, but I think it could be. No.
I really would like for us to talk about that, and that the Macon County Healthcare Authority can serve as a partnership in developing that.
Okay.
Because we do have a clinic here, and in fact, we're in the process of getting it renovating, and we wanted to expand it, and we're looking at having an emergency standalone clinic and different concepts of that. So we're still in development, but I think partnership together can enhance what it is that we're going to provide for the county.
Right.
So I look forward to talking with you
Okay.
about expanding that. Thank
Fantastic.
you.
Thank you.
So much. And a question over here.
So, Dr. Allen, I think that young lady's question segues nicely into what my question is. And Dr. Watson, thanks so much for bringing this to this area. But when I noticed the sites, it's one thing to talk rural America when you're talking Tuskegee. We're here in Tuskegee. It's a decent-sized city and has one of the nation's preeminent HBCUs located. But it's another thing to talk rural when you're talking towns like Evergreen, which is where I am currently living, Monroeville, Brewton, and then yet even further to talk Castleberry and Repton. And so how do you plan to reach those areas, number one? And number two, I noticed all of your networks or enrollment sites are either universities or major hospitals. Have you given any thought to maybe having enrollment sites be, here in Alabama and in the South, community colleges play a major role in educating the citizenry. Have you given any thought to maybe establishing connections with some of those that offer healthcare careers, because they really do a great job in helping to educate the people who are going into nursing and health-related fields in small towns?
Yes, absolutely. I think there's always room for growth and always room for new partnerships. We're not closed to the opportunity to work with community colleges as well as smaller areas or areas where we haven't had an imprint or an opportunity to be there. You being here today is the start of that conversation. So thank you for being here. That's the whole purpose of this conversation and these kinds of activities, is to have those.
But I might not be here if I hadn't spent 30 years in Chicago, and I'm a good friend of Dr. Watson.
There you go. Okay.
So I'm saying we got to figure out how to reach those of us who, I'm here today because of that, basically.
Right.
So,
Right. Okay.
okay.
And you bring up a great point, this concept of access and how do we connect. And one of the things we'll talk about at the end of the day is how do we even think about what resources are needed to invest in Macon County so that they can go out as well. Because we have a mobile engagement asset unit, and we need to think actively about how we use that and we call it an asset unit. It's a big van, a mobile home. And we have to think about how can we get that out to even further to communities. And so my team is here, so this is a call to action, and we need to think about how can we increase that to populations who don't have access. So thank you for that call to action and that charge.
Yeah. Good afternoon. I am Dr. Abdallah from Tuskegee University, Department of Graduate Public Health. Thank you, Dr. Allen, for the wonderful presentations. I really enjoyed it. My question, you stated that people, they should know to ask the right questions. How do they know this is the right questions? Because working with the community, even with my student, if I tell them you have to ask the right question, they're not gonna talk. Because I like them to speak their mind, so we can direct them if this is the right way to ask or not. So could you please just
I think the way that you get to how do you ask the right question, and I was really talking about that from the perspective of those who are question askers, which all of us are. But particularly those who may be in various research fields or setting, how do you ask the right questions? You do that by listening to what other people have to say. I do not know everything. None of us in this room know everything. So it's important to listen. That's a part of the engagement process. I think that's what makes science better, is by listening to what people's lived experiences, what it is that they have to say, and then thinking about what are the questions that need to be asked and answered. So the right question doesn't always come from me. It comes from the community. And that goes back to being present, showing up, being authentic in how you show up, and listening to what it is that people have to say.
Please, I was going to call on you.
Too. For me, I can say that my questions have also been guided by observation as well. So I shared the example of serving as a cancer genetic trainee, and again, noticing which populations were not being served appropriately, or which populations were we really doing a disservice to because of the screening questionnaire that we were using, and maybe the questions that we were using at the time were not the most relevant in capturing their family health history information or their personal health history information. So those observations enabled me to really identify what are some of the questions that are not being asked that need to be asked so that we can better meet the needs of more populations and more patients as well.
Thank you so much for that.
Your panel and your remarks. So since I have all of you guys here, and sometimes the question comes up around race-based medicine. So if we're describing race as a social construction, and then we talk about in the same context that we need more Black and brown people in clinical trials, how do you reconcile that in terms of messaging for communities, and especially people that are concerned that it reifies that there are biological differences between us?
Great question, Dr. Fletcher. I'm going to ask our genetic counselors to start us on, kick us off.
Yes. So in an ideal world, I believe that the combination of race, ethnicity, and ancestry information will be used to really help guide and inform health decisions. As you mentioned, race and ethnicity are social constructs. I believe those constructs enable us to better understand one's lived experience and lived environment, and the exposures that one may endure, which can contribute to risk in the onset of various conditions. And as we delve into better understanding the genome, we identify that there are certain variants, there are certain markers that are associated with various diseases. So I think the combination of race, ethnicity, and ancestry, which is a biological marker, will really ultimately enable us to better service and meet the needs of more patients.
That's a very clear response. Thank you. I mean, it's helpful for people that, are not fully clear. How do you explain this to community members and not discourage them from participating? Because, yeah, thank you.
And we have our time for, and Dr. Fletcher, that's an excellent point. We get asked that question a lot, like, how do we make sure that we don't further widen health disparities gaps by creating, and how do we have this conversation? I really appreciate that clear understanding of the ancestry as a biological understanding of it, and understanding the social things and the social implication of race and ethnicity. So thank you for that. And Dr. Sodeke, we'll leave the last question to you.
Sorry, I think Ms. Cynthia Wilson has been waiting.
I didn't see, I'm sorry, the light is right here.
She's been waiting, so she gets.
And I promise not to be too long because everybody knows I can do that. I'm concerned in terms of the fact that we're looking at rural and urban. And are we entertaining the fact that there's a lot of intermixing with rural and urban? Okay, my country cousins from Shorter also live in Cleveland, Detroit, Chicago, East Philly. So the thinking sometimes that we're dealing with may vary because we've got a lot of people coming back to the South from other areas and bringing their thinking as well. So how, even though we may be the same color, we may not have the same basis, thought pattern related upon where we are in relationship to where you find us at the time of the research. That's one thing. Are you looking at that? Because there are, there's this cross, half of Atlanta is half of LA at this particular point in relationship to that. So that's one thing. And we also had the experience of working, five of our churches, with working with grants that were designed for an urban area and brought to a rural area. And I'm gonna tell you that don't wait. You cannot, so that we make it clear to researchers that when you've got a program that may be working in an urban area, that you may have to adapt it when you get to a rural area in order to be able to make it the most beneficial for that group. And then my last thing is, and this is just a pet peeve of mine from working in bioethics sometimes, is how do we explain to people that not participating in a clinical trial is not participating in a clinical trial necessarily? Because exactly what was said, if you go in and get a prescription, guess what? You just enrolled in a clinical trial. And if none of us were in that clinical trial in relationship to the results of that clinical trial, you are now in a clinical trial that doesn't have the benefit of a researcher looking at the results. How do we make that point to people? Because once you walk in that doctor's office, you want a pill that's gonna make me feel better. And how do I give you that pill if we have not participated in the development of it? So how do we do that? That's what I'm gonna leave with you.
And we will be here next week to talk about, about how we do that. You want to make sure I come back, and I promise I will. We are right at time, but I would be remiss, Dr. Sodeke. We're at time, but I do want to give opportunity for your question.
Thank you very much. I wouldn't be standing here to say what I'm going to say if it were not for the grace of God. The All of Us research program almost got stopped cold. And I won't mention names. But when God gets ready to do something, and the time is right, no one, I repeat, no one can stop it. Unless and until everything that is supposed to be in place is in place. And God is ready to do it. No one, I repeat, no one can force it. That's the way God works. And when God got ready to put the necessary structures in place, that's the reason you and I are here today having this important conversation. Because this community has been through a lot. And as a bioethicist, the very first rule is do not do any harm. If you cannot help it, don't even add more to the pain and the suffering. So that was foremost on my mind. I was the one who insisted that there will be no recruitment of any sort as a bioethicist in this community unless and until we are able to engage this community, feeling the pulse of the community to help us understand what is it, where are we, and how can we help to soften the blow, to help heal the wounds, to engage us in such a way that it will become ours, not just anybody else's. I wanted this community to own it. That, yes, we are up to the point where we know for sure that we really want to do this. And they have to count us because we count. Therefore, this is the reason why we are not a recruitment site today. Because I strongly believe that this community needs to have a say in not only what we should do, but how we should do it. It is only a matter of justice. That's another principle of bioethics. You don't just put people or do whatever it is that you want without really making certain that they are very sure as to what they are getting into, good or bad. I think the community should have a say. And that's why we're here. I give glory to God for giving this spiritual and moral courage to Miss Bernice Fraser to get up there and raise the question, why is it that we are not? Is it because we don't have this structure in place? Yes, we do. And there are programs and there are researchers that can help us do that? Yes, we do. But everybody needs to hear that. And it needs to get into our mindset. Otherwise, it isn't Shodeke that's going to drive a bus down here and say, you all roll up your sleeves or whatever it is. And that is going to conjure up some sense of, oh, here we go again. So until we're actually ready for it, which I'm sensing we are, because I'm standing in victory as I stand. And I'm speaking in victory as I speak. And all of you out there, whether joining us online or seated here, you are sitting in victory because we serve a victorious God. Somebody say amen out there.
Amen.
Thank you.
Thank you so much, everyone. And I want to thank our panelists, and I know we are right at time, a little bit over, and I want to invite the next panel to come on up. But I thank you all so much for your time, and thank you all for participating today.